think we're going to withhold questions to all the speakers because I think they'll tie nicely together. Our next, Ron's talk reminds me of saying somebody in my company said, "We love standards. That's why we have dozens of them." So, Becky Cush is going to be our next speaker. Becky is Dr. Cush is the founder and president and CEO of CDISC, and I'm involved in many of the efforts that you've heard already today. I've had the pleasure of working with Becky on the board for the last 8 years, and so I'm sure you'll enjoy what she has to say.
Thank you very much for having me here today. I heard a rumor that standards almost didn't make the cut because a lot of people don't think that they're necessary. And then we ended up right after lunch, which everybody knows standards are so interesting that I hope that my job here is to let you see how someone can be passionate about this, and Frank knows that that's what I am. So when I saw this magazine, how many of you have seen this one, the Time magazine? Your data for sale, everything about you is being tracked. Get over it. So the author of this went out to find all the data that he could find about himself on any kind of place that he could find that information, and found that about half of it was correct. About the other half was obviously incorrect. And I think when you're talking about clinical research, it's really important to have that data quality. Maybe it doesn't matter if you're marketing shampoo or something, but when your medical needs are in the hands of people with that data, that's important. And I really like this quote. It's an excellent paper that Sharon Terry wrote about the patients being ready to share their data, and it's not the patient that's the problem. So we've heard enough about that today, but I think they are ready to share that data. However, as Frank Rockwell would say, unless we can use that data appropriately or find it, you have broken your informed consent agreement with that patient. So this is really important. And I did this slide well, I had the privilege of living in Japan for 2 years, and this is what, you know, to them is sushi grade data. But there's also the buffet style. So there are different purposes for quality. And I had a talk at one of the IOM workshops on quality, so I put this slide together, which is totally my speculation. But I think that there are different purposes and different needs for quality. And when you're looking at marketing or sales, maybe you don't have to have perfect data. But when you're looking at clinical decisions and clinical research, you want that data to be pristine. So at this point, we've got the sushi grade at the top. And I think that clinical research has really led the path in terms of trying to come up with quality data, because the processes have been developed over the last several decades. And this is from a workshop that was put together by DIA and FDA in the year 2000 with the Road to Clinical Quality Data. And what you see in this list that I won't go through with you right now is there's a lot of things that point to standards, including the one that says standardized, but clearly define the data and specify requirements. That's really what you're doing with the data, and how to limit the number of times the data are handled and those sorts of things. So this is what we're heading towards. Again, I don't want to go through all of this. I don't know how many of you know about CDISC. Not too many raised their hands when Ron asked about it, but we have been around since 1997, started as a completely volunteer group. We incorporated as a nonprofit in 2000, and we are known as a standards developing organization. And we work with a number of other standards developing organizations, ISO TC 215 for healthcare, Health Level 7. We run a joint initiative council around the globe to harmonize standards where we can. But we really focus on clinical research data. That's where CDISC focuses. And this is our vision of informing patient care and safety through higher quality medical or clinical research. And this is our suite of standards. Some of these have 2-day courses that go along with them and how to understand them, but they go from protocol and study design all the way through to analysis and reporting. And the idea is to have all these standards working together and go from end to end in the clinical research process and make sure that they're serving their purpose. And we have the ones that Ron was talking about, which is once you collect all the data on the case report form and put it into the database, then you come up with some tabulations, and that's study data tabulation model, and you have the analysis data sets with the analyzed data with the statistical analyses. And that's where CDISC really does things that are very different than what you would do in a healthcare setting. This is the research piece, and this is the standard for case report forms, C-, which was done under the Critical Path Initiative that Janet Woodcock's known for. And just to make sure that these standards don't break each other and that you can take the data from end to end, we have them harmonized through what we call the bridge model. And we also have controlled terminology that goes end to end to make sure that they work together. And then we have a standard that allows you to transport this information in XML. So again, I don't have 2 days to give a course on those, but what we're really talking about is this is a very interesting piece of information that came out of the Office of Women's Health at FDA when they tried to figure out if they had males or females and how many of them on the studies. And you have M and F in one set of and called sex. Here we have gender and it's male and female. Here we have sex again, but it's zeros and ones. Here we have gender and you've got 1 and 2. So how do you go through this data except by hand to really figure out what you've got in terms of males or females in the studies? The HITSP set has 4 options. HL7 has somewhere around 15. Chuck can tell you exactly. But this is a serious issue in terms of just finding out what sex or is it gender that you have in a study. And so what we've done is try to make it so that we have standards that go all the way from the protocol through the case report form, through data capture in the database, through SDTM and ATOM. And the XML standard that I talked about earlier was specifically designed to carry case report form data, and it's very important and very broadly used within vendors who do electronic data capture tools and other tools throughout the clinical research industry because it supports 21 CFR 11, which is the regulations for tracking the audit trail and when the data were collected, were they changed? If so, why were they changed and who changed them? And this is a very important piece of what the auditors from FDA will audit when they go to a site after they see a submission. So I have 2 slides just to talk about a study that Gartner did with pharma. And this is the business case for CDISC standards. And the summary is that when the standards can save significant time and money and resources, but especially when they're implemented upfront at the beginning. So that goes back to our slide about the road to quality clinical data and building the quality in upfront. The standards did increase data quality. They help integrate data and enhance reusability. If you map at the back end, you lose about half of the information, and it facilitates exchange with partners. And interestingly enough, it improved team communications because they could always talk about this and talk in the same language. And it allows you to choose and pick software tools because if those tools support the standards, then you can exchange tools and you still haven't lost the data that you're trying to share with others. So this is just a slide showing the value that you mostly get the value if you implement them upfront in the process. Bridge, I mentioned Bridge earlier. I want to talk just a little bit, and Chuck will follow me, but talk about how CDISC and HL7 complement each other. And we've worked with HL7 for the last decade. One of the models that's a collaborative model that is core stakeholders, CDISC, National Cancer Institute, FDA, and HL7 have a collaborative model that's open and it's global and it's put together to represent protocol-driven research. And we called it Bridge. I can tell you what that means. It's down here on the bottom of the slide. But the main idea was that it bridges all the standards together, it bridges different organizations, and it bridges healthcare and research. And it actually has a layer that's mapped to the HL7 RIM. So one of the other pieces of information I wanted to share today, we were just talking about meaningful use and the use of electronic health records. We had the last use case that made it through the HITSP process when the HIT standards panel was convened, and now this hasn't gotten into meaningful use with the HIT Standards Committee quite yet, because they're still trying to get people to use electronic health records and exchange some preliminary information. But in meaningful use 3 and 4, this will become very important. And the use case was, how can we allow the EHRs to be different EHRs at different sites and yet share a core high-quality set of clinical research data. So this is, this is called an interoperability specification. It makes use of 3 standards. One is the continuity of care document, which is based on some work of HL7, and also that comes out of the EHR because that's the way to exchange information between EHRs, but we use an integration profile that's developed through integrating the healthcare enterprise, and it's very powerful. It actually takes an electronic form that's managed remotely into the EHR setting, collects the data that it can out of the EHR, you enter the remaining data, and it goes off back to whoever needed that form. So it's a way to collect a key set of information, and in this case we're talking about CDASH, which is a core set of clinical research information that is required across all clinical trials, and it's known around the world. So you can produce a standard core research data set. It also enables 21 CFR 11 compliance, and it allows you to have multiple different EHRs in different sites and still produce CDASH, which is the standard case report form information, and then you can enter again the data that you still need for the trial. And this RFD is being implemented in Europe, in Japan. We have had it done in some post-marketing studies in the US, and there's a challenge out now to have it done on an actual regulated study. It has also been used on a study to do adverse event reporting, which Pfizer supported at Harvard. And you can see the power of this as a workflow tool, not just standard, but a standards-based workflow implementation, in that doctors at Harvard who had never really been reporting adverse events because it took 35 minutes out of their day, time to see a patient or two, and by implementing this, they were able to report adverse events in less than a minute, and it started happening. So this is a real workflow improvement effort. And CDISC does not work alone. I didn't do all this work. We have thousands of volunteers around the world, and I just wanted to point out a few of our key partners. The National Cancer Institute houses all of our controlled terminology in their enterprise vocabulary services. You just heard about CPATH and our partnership, and you will hear more about it in a few minutes. Duke we work with, and they started actually some of the therapeutic area standards that we've been doing through an NIH roadmap grant. And TRI, which is the Translational Research Informatics Institute in Japan, when they provide funding for the studies at academic settings, they tell them to use CDISC standards. And IMI, I was just at IMI Tuesday. They are teaching the consortium members for about 23 projects about CDISC and saying, use CDISC if it's available. If not, help them develop the standards that need to augment what we're doing. And Transcelerate, I won't go into that. You just heard from Ron about Transcelerate. I will leave you with a tool that we still need to produce, which we call SHARE, which is Shared Health and Research Electronic Library. So what we're finding is that we really need to put a lot of these standards, which are on paper and in spreadsheets, into a way that they're readily accessible electronically. They will help us develop this therapeutic area standards that Ron Fitzmartin just talked about easier, and to share them and make them more broadly available. And so that's a tool that we are looking at how to develop and how to collaborate on it, because CDISC wants to collaborate and make all these open and freely available standards like the standards we already have. And this is my last slide, is to talk about what I see as the desired criteria for standards to facilitate clinical research, which is that they are fit for their purpose, and that is going to come out more in meaningful use. Not all of the EHR standards are going to work for research purposes, so we need to make sure we have what we need. They need to be global because clinical research is a global exercise and is happening all around the world. We have at least 90 countries downloading our standards right now. We need to make sure they're based on GCPs and applicable regulations, and that they're harmonized from end to end, that they're developed through an appropriate SDO process, and that they're not proprietary. We've been joking about all the standards out there, but there's really, it's not that you need proprietary or redundant standards. You need people to agree, and there is no right or wrong in standards. It's how are we going to agree to go forward and use these. And they need to be platform independent and encourage innovation, not make it so it's difficult to do what we want to do. We have to make sure that people can design trials the way they need to design them and still use standards to exchange the information and then to support a link with healthcare. So I hope I left you with something that lets you see that CDISC isn't just standards, but also a number of other activities that we are trying to promote to help facilitate research.